kidney medical bills that are running into millions.
Thank you. Thank you, Mofaya. Senator Mofaya.
Thank you, Session Chair. Waziri, the discontinuation of Linda Mama program has led to a regression in maternal health care, as is in Kenya, which is important to.
Please don't read. Just
I'm not reading. I'm quoting.
Just please.
We have very many mothers retained in hospitals. So what is it that is doing to make sure that we have access to this kind of program in future?
Senator Mbugua.
Thank you, Chair.
Anasema hajasikia kuhusu unasoma.
Don't be reading.
Just repeat your question.
I am saying the discontinuation of Linda Mama program in Kenya. Discontinuation.
Asante, Senator Mbugua.
Thank you, Chair. Waziri, when we re-ministry table to Parliament the national policy for identifying and enrolling indigents into the SHA system. Thank you.
Thank you, Senator Ezena.
Thank you, Whip. And this question arose from my community engagements in Samburu, and the residents would like to know what has SHA done to ensure inclusivity of under 18-year-olds who are totally orphaned and have no primary dependent. Thank you.
Thank you, Senator Eddy.
Waziri, may you explain to the country the rationale for denying services to patients who have not made a full year contribution, even when they have contributed up to date at the time they are seeking treatment?
Thank you, Senator Hamida.
Thank you. Bwana Waziri, what is the status of the unpaid debts and unsettled claims so far from NHIF, which still lingers and has not been resolved?
Thank you. Last but not least, Professor Tom Ojenda. If you had already asked a question, please allow your colleagues to go. Let's hear from Professor Tom Ojenda.
Thank you. To the CS, this is a question that is generic. CS, what is the status of this saga involving the Kenya Medical and Practitioners and Justice Council, KPMDC, and the demand by KPMDU that you disband the council?
Thank you. Thank you, Prof. What is this comment that is banning Senator Beatrice? 1 minute, please.
Chair, I was just requesting Dr. Mott to add negligence as a cause of maternal deaths in this country.
Thank you very much.
And it is critical. Yeah.
Asante sana, senators, for making my life easy. And I apologize if I have cut anybody short or cut anybody out. We are running out of time. CS, please. Let's take those responses and then we'll hear from the Governor from Mombasa.
I think I'll start with the Senator and Chair. Global Fund staff. There are not many. There are about 90. We have factored them in our budget this year. And once that's finished, we will they'll be back and we'll pay the budget will be from July last year. And I think on the issue of let me say these honorable senators and honorable speaker, that the foreign treatment for many years in our country later became a cartel business between doctors in India and some also doctors in Kenya. There were certain treatments that can be done in our country. Kenya is one of the countries with the highest human capital. So the Benefit and Tariff Panel Advisory Committee, working with the DG, have flagged out only 37 ailments or treatments that Kenyans can only go out of the country. And that one I have gazetted. So if you want to go out of the country and pay from yourself, we have no problem. But if you want to use public resources, your own insurance, under SHA, it must be within that 37. On those who were there before the disbandment, I don't want to again go into trouble with the chair. Honorable Chair, you did not put the transitional clause. When you are transiting from NHIF to SHA, that should have been captured in the Social Health Authority, a transitional clause that says those who are out of the country, and that was all done. So a new outfit was created called SHA. So we have to live with the new SHA rules. Then I think there were 3 hospitals you said on bed capacity. And I think there was somebody who asked, let me just answer. Kenyatta National Hospital, one of our biggest referral, had a bed capacity by law of 1,800. But they used to admit 2,200 and allow people to sleep on the floor. Today, if you go to Kenyatta, they can only admit 1,800 and nobody is sleeping on the floor. So if you see any hospital, an hospital these days, they don't see the urge to put 2 mothers on the same bed or to sleep on the floor because SHA will not pay. SHA will pay. So before the urge was because of the former NHIF. NHIF was paying for those who are even on the floor of the hospital. On FIF, I think also somebody asked. I think from my previous experience, national legislation is superior to county legislation. There are some counties that have created their own FIF. And the governor here is saying it's true. The Senate must be very firm and say that the law that will exist is the FIF Act legislated by the Senate. Those governors, they must be told in black and white. I have tried, but they don't want to listen. Honorable Wakoli from Bungoma, I think Mercy will ask. We have a plan on how to integrate HIV into SHA benefits, but you'll speak to it. Senator Betty from Kitui, I think. Yes, the biggest challenge we are facing is corruption. Not only in facilities, even in our own institutions, KMPDC, even in SHA, but we have made it very, very clear that there are no sacred cows. We even have corruption in faith-based facilities where we expected the highest standard of ethical. So we will, yes, there's one in Likoni that I thought it was owned by the governor, but later it became owned by a faith-based, and we are about to do it. I think the senator for Samburu, maybe I didn't get it, but it was about missing medicine in the facilities.
Issue CS was, somebody goes to the hospital, there is a prescription for drugs, they don't have that drugs in that facility, they have to go and buy, but when the hospitals are claiming, because it's already on their records, they also claim the money for...
No, in fact, what is happening, and this is going to shock you, our system has detected in 5 counties, I don't want to name them, but let me name the first one, because the governor has agreed with me, Kakamega, that 52,000 patients went through the system, and only 9,000 got drugs. We went to another county, 36,000 went, they went to the lab, they saw a doctor, but when it comes to dispensing of medicine, only 4,000 got it. The question is, maybe the healthcare workers in that facility, and that's why you see, I don't want to use again another example. In a number of our PGHs, the compound is surrounded by chemists. Every hospital, PGH in every county, you see around the hospital, there are over 200, 300 pharmacies. Those pharmacies, the drugs they use are the ones stolen from the hospital. So what are we doing? Now the system we have designed, and Anthony is here, is going to maybe speak to it, that if you have not dispensed a drug or a medicine to a Kenyan patient, SHA will not reimburse. It will help us in 2 ways. When SHA does not reimburse, the amount of money goes down. So you'll be forced to have the medicine. But this problem is there. And please look at even, I can name a number of counties I've visited. There are more pharmacies than even the buildings there. So we will we'll deal with it. There was a question by our nominated senator that I leave it to Mercy. Honorable Mtata, the issue of tribunal, you are very much aware. For us, anybody who wants to defraud SHA, we have, under law, we have the powers to suspend him. We have powers not to pay him. And all facilities have dashboards. They can see why they are rejected, the reasons, the claim. And I want to say, since then now, what we have done is that now the system has improved. It won't accept your documents if there are documents missing. It will tell you, no, bring that document. So the rejection has reduced by about 60%. Kenyatta National Hospital, for example, the last 2 months has not filed any rejection. So we are also doing, SHA is doing clinics, Mercy will speak to it, where we are educating hospital claims officers and admins to do that. The tribunal, it's the judiciary that has brought a law to Parliament. I think it's in the National Assembly, where they say we want to consolidate all tribunals into one. And we have been told not to operationalize. Tomorrow, if both houses finish that consolidated tribunal of the judiciary, I will operationalize. People can go to the tribunal. But for now, I have to protect public resources. On the 104 billion, that is a matter in court. We are with you in court. We will argue our case in court. You'll argue your case in court. And the courts will make a decision. I think it's not for the Senate. Honorable AC, I think oncology, yes, 800. Mercy will speak to it. But you know, even after the pronouncement of the president, we are ready, willing, but we must follow the law. So the benefits and advisory tariff panel is we're doing public participation. We don't want, again, somebody to go to court and over how we spend money. Honorable Ambo, I think your first question was to DG. DG will answer. The question of Honorable Marzayo, I think, is a public health risk and threat. And I agree with him. And I think, DG, you must pick it. Yeah, we must sit with the Ministry of Interior, and we must bring to conclusion those bodies. You can't have bodies in a container for all these years. It's going to be a serious public health threat. And we're the custodian of public health. So we will pick it up, and you will see it. Honorable Member, our Senator from Elgeyo Marakwet, I think Mercy will answer that. Senator from West Pokot, patients detained. Patients are detained for many reasons. But I think it's not right for patients to be detained. For example, Kenyatta National Hospital, we have a fund, a disaster fund. And when we confirm that that patient cannot pay, we use that fund. We even used it during the many riots in Nairobi. But Senator, you need to help us. Because of the strike in Nairobi, our referral hospital is overwhelmed. And we have written to the governor a number of times. We have written to the governor. He needs to resolve that dispute. The same with Kiambu, when there was a many months of strike in Kiambu. We had the same problem. The Kenyatta Hospital and Kenyatta University Referral Hospital overwhelmed. So you need to help us. Honorable Senator Tobiko, burden of extra cost. The 500, Mercy will answer that. I think I have finished mine. Maybe Mercy, and Mercy, you must speak a bit louder for the senators to hear from at the back.
And a bit faster.
And faster.
And
okay.
yeah, there was a question by the senator nominated senator from Mombasa.
Senator Miraj.
Miraj, what was it?
The number of facilities that have complied with the Green Charter, penalties that exist with the facilities that are charging illegal fees, and the compliance, how the monitoring of compliance is made.
Mercy, you take that. But there was a question by the host senator, I forgot, on Nakuru. She's very busy with the phone. Yes, number one, I want to say that Nakuru PGH is the best in terms of compliance. I am proud of the doctors and the people who run in terms of claims. They have some rejection, but I think after Nakuru's Nairobi and Mombasa, we have received of $1 billion or close to $1 billion. Nakuru has received 1.2, 1.3. I think now they have reached 1.5 billion. But I agree with you that please report to us. Report to our call center, 147, either email or telephone or WhatsApp, if you see that there's a facility where our patients are sharing beds, because that's illegal and that is not care and that's not dignified. When two people share a bed, that is not care. You're not giving them any care. So please help us. And then the one on the FIF, I think the governor is here. This thing is going to land me into problems. This should be a discussion between the governors and the Senate and the legislature. So Senator Abdul Samad will answer what is happening with FIF in some counties, maybe not his. Mercy.
Thank you. Thank you, Waziri. Thank you, Session Chair, Honorable Speaker and members. On the overseas program, this is progressive. UHC globally is progressive. And Kenya is starting with a 500,000 package. And with more resources, with more registration and payment, this package will be improved. The process of doing this is through the Benefits Advisory Tariff Panel, led by Professor Jauko. He has already started a process of review, and he will be inviting and also interacting with this House in terms of enhancing the benefits. In terms of the old NHIF pending bills, both overseas and national, one, we have finished verification of all bills under 10 million, and these will be paid out. We are hoping to get resources in the coming supplementary budget. And we've already started, again, verification of bills overseas, which come to about 125 million, and those that are local, that are about 24 billion. And that process is underway. With regards to people living with HIV, this is how our benefit package looks like. If you have HIV, you're able to access inpatient, outpatient services, radiology services. You're able to get your medications through the medical bed rebate. If you require any surgical procedures, you're able to get those surgical procedures. If you require any dialysis in case you have kidney failure or issues to do with the kidney, you're able to access the dialysis package. So our package as is right now is actually accessible to HIV patients. Remember, HIV in Kenya is a strategic program, and we do have the commodities availed through the Ministry of Health. Progressively, what are we doing? In collaboration with USG, we do intend to ensure that the reimbursements for medicines for HIV will also be included in the SHA package. And we have the costings for that. We are working with the PS Medical Service to ensure that takes place. Yes, and DG is telling me here that 97% of Kenyans living with HIV have achieved viral suppression. And that's a good indicator in terms of how our program is working. Then the PHC fund. The PHC fund is funded through what we call global capitation. And honorable members, here's where we need your support, because if your counties register, it means they get more PHC resources. Counties that are below in registration are actually getting very little PHC resources. As we stand right now, Samburu is second last with just 28 million, while Nairobi has gotten 1 billion. And it's all a factor of your registration. Number two, if you look at the Emergency Chronic Illness Fund, again, this fund is accessible to all Kenyans, and you do not have to have registered for SHA. If anyone has an accident, you're on a boda or any type of accident, and it's an emergency that fits our benefit package, you can actually walk in to any level 6, 5, private public FBO facilities and get care for the first 24 hours on the account of government. Now, past 24 hours, your shift would need to kick in to be able to meet your bills. With regards to the green charter and the green label for level 2 and 3 facilities, we are mapping out compliance, and this is being done through the county SHA branches. As it stands right now, we are aware that some counties are co-charging, and we will soon be able to release that list once we finish the compliance mapping. With regards to implementation of the enhanced SHA benefit package, again, this process is being led by Professor Jauko. He is intended to give to the Cabinet Secretary an advisory by 1st of October this year. That advisory will have the packages that will be enhanced and the ones that will be reduced. And so active participation will be required, so then we have now the next version 2.0 benefit package. When it comes to registration and payment, indeed, the honorable member is correct. We do have Kenyans registering, and we are working to ensure that those who register do pay into the fund. We have different activities that we've rolled out to this regard, including deployment of our SHA offices, compliance, messaging, communication on the benefits of enrolling into SHIF. Patient detention is illegal in Kenya. We're not allowed to detain patients, and any providers who are detaining patients, particularly on the basis of SHA, would be doing that illegally and would go through the system for that. In terms of raising medical costs, again, UHC is a journey. We have to work continuously to contain medical costs, and they escalate everywhere globally. Estonia has 14% of their pay slips deducted for their healthcare. Singapore has 10%. Kenya is at 2.7%. So it's a progressive journey that countries continue working towards to improve the resource basket for UHC. Now, under 18-year-olds can be registered through their households. However, those who are orphans and do not have principal members can also be registered and can access SHA, and we'll be able to provide that information on the website. We also do have covers for orphans, and that's at 300 Kenya shillings for the orphan, and they'll be able to access all services. With regards to full year contributions, this is in the law. The law provides for annual premium payment. And the reason for this is because if we look at NHIF, Kenyans used to pay 500 shillings, access a surgery for 100,000 shillings, and then never return to pay. This then meant that the fund was unsustainable, and that's why we have the annual contribution. For Kenyans who cannot afford the annual contribution, we have SHA Lipa Pole Pole, and on the direction of the minister, we've also expanded this to include other insurance premium financing facilities that will soon be unveiled to all Kenyans. Regarding NHIF pending bills, as highlighted, 5.3B has already been reviewed and will be included in the upcoming supplementary. Then we'll get to bills above 5.3 billion for facilities who have bills above 10 million. In terms of maternal deaths, I think DJ will touch on that. The emergency package being available in all level 6, 5, and 4 hospitals that have theaters. Again, this list is available in the SHA website and will be disseminated to everyone. The oncology package, as highlighted by Waziri, yes, the 800 limit is now in the system. We'll be going through public participation, submitting the regulatory impact statement, and getting this on legal notice so that Kenyans can access this. We anticipate this should be done within